Hello, this is Chris Frigno. In this video, we'll discuss the posterior thigh compartment as well as the gluteal region. In association with this discussion, we'll also have a discussion on the hip joint that you'll see separately. In this first of two parts, the gluteal region will be discussed. The second part will discuss the posterior thigh region as well as the popliteal fossa. The gluteal region represents the transitional zone between the trunk and the lower limb. Specifically, it is the area posterior to the pelvis between the iliac crest and the gluteal fold. The left and right gluteal regions are separated by the intergluteal cleft. Yes, believe it or not, that's the anatomic term for the butt crack. Large amounts of both muscle and fat make up the buttocks. The muscles of this region are generally responsible for abducting, that's abducting, extending, and laterally rotating the femur at the hip joint. In regards to the osteology, the gluteal surface makes up the posterior portion of the ilium. If you look closely on this pelvis or on this ilium, you can see the posterior, anterior, and inferior gluteal lines, which are demarcations for the attachments of the gluteus maximus, gluteus medius, and gluteus minimus muscles. As I toggle between slides, you can see these gluteal lines. Inferiorly, we can see two sciatic notches. Here we can see the greater and then the lesser sciatic notches. These are going to help form the greater and lesser sciatic foramens. In between the two is this protrusion of bone or prominence called the ischial spine, off of which will come one of your smaller lateral rotators in the deeper portion of your gluteal region. Also inferior, we've seen this before, we have the ischial tuberosity, which is going to be a point of attachment for all three long hamstring muscles. We can now get a complete picture of the obturator foramen and its bony constituents. Recall we had the pubic bone anteriorly, and it gives off an inferior pubic ramus, which joins in with the ischial ramus from the ischium. So this whole structure down in this area is called the ischiopubic ramus. Superiorly, we have the superior pubic ramus that extends into the acetabulum, and then coming off the posterior side of this acetabulum would be the body of the ischium, and then of course the ischial tuberosity. So what structures make up the obturator foramen? Well, we have the body of the pubic bone, the superior and inferior pubic rami, the ischial ramus, the ischial tuberosity, the body of the ischium, which is more up in this region, and the lower margins of the acetabulum. Here we can see a posterior pelvis and a posterior innominate. This is also a posterior innominate, although we're looking more at the lateral side of it, this gluteal region here, which is this gluteal surface. We can see the PSIS, which we can make out over in this area. And this PSIS is in close proximity to the lateral sacrum. We're going to see some muscles coming off of the lateral sacrum today. And of course, we have this lateral sacrum as we go inferiorly connected in with the coccyx. Here we see an image of the proximal femur. We're showing the posterior aspect of the femur because we're looking at the gluteal muscles, which are either going to come in over the top onto the greater trochanter of the femur or posteriorly in this region. We're going to see several muscles attaching to this greater trochanter, particularly those lateral rotators and abductors. The gluteal tuberosity, right in this region, is a roughened area, of course lateral to this pectineal line that's the attachment for the gluteus maximus. And once again, we'll see muscles attached into the linea aspera, particularly the biceps femoris short head muscle. In this overview slide, we see that the muscles of the gluteal region are divided into a superficial group of 4 muscles and a deep group which contain 5 muscles. In general, the superficial group of the gluteal muscles are responsible largely for abduction and extension of the thigh, and the deep group is largely responsible for external rotation of the thigh, but also realize that both of these are broad generalizations.
The gluteus maximus is a very large and strong muscle with a broad point of origin that encompasses the sacrum, the ilium, the sacrotuberous ligament, and the thoracolumbar fascia. As this wide muscle obliquely crosses the hip joint, it attaches to the gluteal tuberosity and also to the iliotibial tract, which descends down the leg to insert onto the tibia. The size and orientation of the gluteus maximus makes it a very powerful extender of the hips, and we can see that here in both the standing and supine position, and functionally very important when trying to ascend stairs or get out of a chair. Note that in both of these functional movements, the hip is in a flex position and the person is going out of this hip flex position into a hip extended position. The oblique nature of its muscle fibers also allow the gluteus maximus to assist with hip external rotation. The gluteus maximus is served by the inferior gluteal artery and the inferior gluteal nerve. We'll see images of this nerve and artery in later slides. Gluteus medius and minimus are fan-shaped structures that share an insertion and a nerve supply and have nearly identical functions. In this picture on the left, the gluteus maximus has been removed to reveal the deeper musculature. Similarly, on the picture on the right, the gluteus medius here has been removed to reveal the gluteus minimus. The gluteus medius therefore lies just deep to the overlying gluteus maximus, and it's helpful in a cadaver to look at the fiber direction to differentiate the two muscles. The gluteus medius runs more vertical, particularly on the lateral surface in this region, while in the posterior region it is a little more oblique. However, this region is generally covered by the gluteus maximus. Both the medius and the minimus attach to the greater trochanter of the femur. Therefore, when these middle fibers of medius and minimus contract, they're going to effectively abduct the femur at the hip joint. Secondary functions for both muscles, particularly the medius, would be that the posterior fibers could effectively laterally or externally rotate the femur at the hip, and then the anterior fibers, not very well seen here in this picture, could medially or internally rotate the femur at the hip. That said, the primary function of the medius and minimus should not be overlooked. Their primary role during routine function, i.e. while we're walking, is to stabilize the pelvis while the stance limb is on the ground. In this individual, they're swinging their left limb through. The right limb is on the ground. The right gluteus medius is preventing the pelvis from dropping to the left-hand side. This occurs because the femur during the stance phase of gait is fixed, essentially fixed on the ground, so it's stable, allowing for a stable attachment of gluteus medius and gluteus minimus. And then the contraction pulls the ilium towards the greater trochanter, thus stabilizing the pelvis. You might be wondering what these yellow circles are. These are drawn in just to indicate the superior gluteal nerve innervating gluteus medius and minimus, and the other muscle that we'll get to in a second, tensor fasciae lata. This one indicates the inferior gluteal nerve, which innervates the gluteus maximus. Thus, the inferior gluteal nerve is innervating gluteus maximus. Superior gluteal nerve is going to innervate these more superior muscles, the medius, minimus, and tensor fasciae lata. These nerves are separated by this muscle here, which we'll see in a minute as one of the deep rotators, as the piriformis muscle. The image on the left is showing the exact same thing. In this case, the person is standing in the right limb, the right gluteus medius and minimus are firing, thus keeping the pelvis either at a level state or, if it's a robust contraction, elevating the opposite side because the distance between these 2 points is shortened, which depresses the right ilium towards the greater trochanter on the right, while elevating, because the pelvis acts as a unit, while elevating the left side of the pelvis. With an insufficient contraction of the muscle, either due to a nerve lesion to the superior gluteal nerve, or some sort of hip joint pathology where the muscle becomes effectively inhibited from contracting, the gluteus medius or minimus are unable to support this level pelvis. Therefore, without this contraction during the right limb in the stance phase of gait, the left side will drop downward. And that's called a positive sign for Trendelenburg gait. So in this case, this patient here would have a Trendelenburg gait. So if this concept still isn't quite clear for you, I recommend that you watch this excellent video linked here. You may recall that the iliotibial tract is a thickened vertical band of fascia that emanates from the iliac crest and extends all the way down the lateral thigh and inserts onto the anterior lateral tibia on a specific area called Gerdy's tubercle on the lateral condyle. In part, the iliotibial band helps to stabilize the lateral knee when it's extended. Two muscles merge into this iliotibial band, which is again a specialization of the fascia lata of the thigh. We've previously seen that the gluteus maximus comes in and inserts into this band. And now we'll see the tensor fascia lata anteriorly coming down off the iliac crest close to the anterior superior iliac spine and descending down and sending off its tendon into this iliotibial band. Because the tensor fascia lata is anterior to the axis of rotation of the hip joint, it can play a role in hip flexion. Because it's lateral to the hip joint, it can play a role in hip abduction, along with the gluteus medius, the gluteus minimus, as well as contributions from the gluteus maximus. The superior gluteal nerve, which emanated from above the piriformis muscle way over here in this area, travels along, innervates the gluteus medius on the underlying gluteus minimus, and then goes and innervates this tensor fascia lata. Thus, it's covered in the posterior region and not in the anterior thigh. To quickly review the superficial group of the gluteal muscles, we saw the gluteus maximus most superficially and posteriorly, and underlying the uppermost portion of gluteus maximus would be the gluteus medius. Underlying it would be the gluteus minimus. And anterior to all of these, not shown on this picture, is the tensor fascia lata that comes off the iliac crest, again anterior and lateral. With the gluteus maximus removed from both images here and then here as it's cut, we can now appreciate the deep group of the gluteal muscles. These muscles are all going to attach posterior to the mechanical axis of the hip, making them all lateral or external rotators. So we can start here at the top, seeing the piriformis muscle, and then some smaller muscles down below it. Note they're all going to insert somewhere onto or very close to the greater trochanter of the femur, and they're all going to help to stabilize the hip joint in addition to externally rotating the hip joint. The piriformis muscle is the most superior muscle of the deep group. It originates from the anterior part of the sacrum. That's hard to appreciate here because it's obscured by the ligamentous structures. But it comes not from the posterior aspect of the sacrum, but anteriorly, and then it emanates out of the greater sciatic foramen to insert onto the upper portion and posterior portion of the greater trochanter. Because it is the most superior muscle, it does have the ability to help with abduction of the femur at the hip joint. Just inferior to piriformis, we're going to see the first of two gemellus muscles. The first one would be the gemellus superior. 2 muscles down from that, we're going to see the gemellus inferior. The gemellus superior emanates from the ischial spine. So here we can see the bony ischium kind of turning inward a little bit, and that's where the gemellus superior is going to emanate from. And again, it's going to travel laterally to attach onto the greater trochanter. You can see now with the contraction of this muscle, this is a pure rotator of the thigh. Of course, it's going to stabilize as well. Just inferior to this gemellus superior muscle would be the obturator internus. In my opinion, one of the most perplexing muscles in the body. This muscle emanates, because remember its name is obturator, it emanates from the obturator foramen, much of its attachment being on the obturator membrane. It projects upward and then takes a 90-degree turn around the ischium to head towards the greater trochanter. Arising directly off the ischium is the inferior gemellus muscle, again projecting also to the greater trochanter. Gemelli, by the way, means twins. Here we see gemelli pasta, coined by Italians because of the intertwined 2 twin pasta strands. The last muscle we'll see in the deep group of these lateral rotators is the quadratus femoris muscle. Quadratus femoris attaches from the lateral edge of the ischial tuberosity and extends laterally to attach into this area called the intertrochanteric crest. See the lesser trochanter and the greater trochanter. So this would be the intertrochanter crest. Remember, on the anterior side of the femur is the intertrochanteric line. There is an extensive and robust ligamentous network in the posterior gluteal region. The 2 major ligaments include the sacrotuberous ligament, connecting the sacrum to the ischial tuberosity, and the sacrospinous ligament, connecting the sacrum to the spine of the ischium. Recall that part of the gluteus maximus attaches to the sacrotuberous ligament. With the help of notches in the pelvis, these ligaments help to form foramen, called the greater and lesser sciatic foramen. The greater sciatic foramen, which is shaded here in yellow, is a passageway for structures to enter and leave the pelvis. The piriformis emerges out of this greater sciatic foramen, again stemming from the anterior aspect of the sacrum, going through the greater sciatic foramen to insert onto the greater trochanter. Different structures exit above and below piriformis within this foramen. Superiorly, we can see the superior gluteal nerve innervating gluteus medius, minimus, and then traveling over to innervate the tensor fasciae lata. The superior gluteal artery serves these 3 muscles in addition to the gluteus maximus muscle, especially these upper segments of the muscle. Inferiorly, we see many structures, primarily the inferior gluteal nerve and artery. Remember that inferior gluteal nerve is serving only the gluteus maximus. The inferior gluteal artery is serving primarily the gluteus maximus, but also hitting some other muscles in this region, particularly those deep rotators. Most importantly, we see this nerve called the sciatic nerve that's going to emanate again through the greater sciatic foramen underneath the piriformis muscle. It's going to extend down through the buttocks into the posterior thigh and ultimately innervate the structures in the posterior thigh as well as the entire leg. A few other structures just to note here that come out of this greater sciatic foramen are the pudendals, so the pudendal nerve and the internal pudendal artery and vein, which are going to come out of the greater sciatic foramen and ultimately just go into the lesser sciatic foramen. The lesser sciatic foramen is formed by both ligaments in this region, the sacrotuberous ligament and the sacrospinous ligament, as well as the lesser sciatic notch of the ischium in this region. Keeping these neurovascular structures in mind is important when doing injections into the gluteal region or doing an IM injection or intramuscular injection. In the safe area, you avoid the superior and inferior gluteal nerves and arteries. To locate the safe area, one would palpate the ASIS with the index finger and make a V, a wide V, with the index and middle fingers, and this would constitute that safe area for those injections. As the sciatic nerve exits out from underneath the piriformis muscle, it can become compressed.
This condition can be more common in those who have the sciatic nerve piercing the piriformis muscle. In other words, here we see the normal configuration where the sciatic nerve comes out from underneath piriformis muscle. In about 15 to 20% of the population, the sciatic nerve exits through the mid-substance of the piriformis muscle, thus making it vulnerable to being compressed.
If the sciatic nerve is compressed and adversely affected by the direct compression from the piriformis muscle,
then that individual has a piriformis syndrome with a resulting sciatica.
Now, bear in mind, this is only one cause of sciatica and a much lesser common cause than a compressed nerve root located higher up in the lumbosacral region of the spinal column. For instance, it's much more common for sciatica to be caused by a herniated disc compressing the nerve roots. If a patient presents with shooting pain down a leg, a common clinical procedure is to do a series of two tests, the Lessegs test and the Bragard's test. Lessegs test involves raising the straightened leg into the air and looking for some sort of buckling. Either the knee will buckle or the patient may raise up their lumbar spine off the table in response to a painful stimulus. This is because the sciatic nerve courses posterior to the hip joint and posterior to the knee and ankle joints. Therefore, as you raise the leg up, you're lengthening the already affected sciatic nerve, and that produces pain either in this area or in the hamstring area or in the calf area.
With the leg raised, the clinician can then proceed to the Bragard's test.
The Bragard's test takes this already straight leg raise at the point of buckling, raising it or lowering it down a little bit, and then dorsiflexing the ankle. Again, if the same symptom is produced with ankle dorsiflexion, either here or in this region, that's a positive test suggesting that there is impingement somewhere along the course of the sciatic nerve, most often again in the lumbosacral spine.
This is the second of a two-part series on the gluteal region and posterior thigh compartments. The posterior thigh contains a total of 4 muscles. 3 of these 4 muscles are part of the hamstrings. On the medial side of the posterior compartment are the semitendinosus muscle most superficially, sending its long tendon down. Underneath it is the semimembranosus muscle. Laterally, we see the long head of biceps femoris. Now remember, biceps means 2 heads, so this is the long head is part of the hamstring group. We'll see in a minute the short head is not part of the actual hamstrings, but is a component within the posterior thigh. All 3 muscles of the hamstrings have a common attachment point here at the ischial tuberosity, and they all help to extend the femur at the hip or extend the thigh at the hip while flexing the leg at the knee or flexing the tibia/fibula complex at the knee. Going back to the medial side of the posterior compartment, the semitendinosus extends down from the ischial tuberosity and extends down and inserts here onto the medial tibia via, again, the pes anserinus. So this is the third component that we'll see feeding into the 3 muscles that make up the pes anserinus. Recall that the other 2 muscles were the sartorius muscle from the anterior compartment and the gracilis muscle from the medial compartment. The semimembranosus will course down and insert directly onto the medial tibia, and the long head of biceps femoris will extend again on the lateral side, and instead of going into the tibia, it will attach onto the fibular head.
Do you remember any other structures that might attach here? One of those structures would be the lateral collateral ligament coming into that fibular head as well. The short head of biceps femoris is not part of the hamstring, thus it's a bit of a loner. Here we can see the biceps femoris short head arising from the femur along the linea aspera. This might give a slightly better view. And it courses down and crosses the knee, attaches also onto the head of the fibula, as well as the proximal lateral
Tibia.
So realize this only crosses the knee joint and does not cross the hip. Thus, the short head can only act at the knee, thus flexing the tibia at the knee. Here we can see the innervation of the posterior thigh. We've seen in the posterior gluteal region the sciatic nerve exiting out from just below the piriformis muscle. Note that it courses down the posterior thigh, ultimately in the mid portion between the semimembranosus and tendinosus and then the long head of the biceps femoris. That's a little hard to appreciate here because we see it here on the medial aspect, but you can see here that the muscle will course generally lateral to this distal component of the sciatic nerve. Along the course of the sciatic nerve, it's going to send off muscular branches off the medial component of the nerve itself. So realize that the sciatic nerve is actually a bundle of two nerves. The tibial nerve, here we can see the tibial division of the sciatic nerve, and then laterally the common fibular nerve or the common fibular division of the sciatic nerve. So in the posterior compartment of the thigh, we're going to say that the three hamstring muscles, in other words, the biceps femoris long head, the semimembranosus and tendinosus, are all going to be innervated by the tibial division of the sciatic nerve. Again, this short head is a bit of a loner here because it's innervated by the common fibular division. Here we can see it termed the common fibular division of the sciatic nerve because we can see this branch of the sciatic nerve coming off the lateral portion. Again, that's going to be the common fibular division of the sciatic nerve. This sciatic nerve typically divides after it's given off its muscular branches in the posterior thigh, and it will ultimately divide into a tibial nerve and a common fibular nerve in the popliteal fossa or proximal to the popliteal fossa.
So there's no doubt that each one of you have heard of someone straining their hamstring. Again, a strain is pertaining to a muscle and its associated tendon, while a sprain is associated with a ligament connecting two bones. Hamstring strains are very common in sport and can be quite debilitating and very slow to heal depending on where they are. The most common is a biceps femoris tear, and the most aggravating here would be the proximal strain up here in the biceps femoris. So two factors come into play when predicting recovery. Generally speaking, the higher the injury, the slower the healing response. Also, as you might expect, severe strains take much longer to recover than mild strains. So a grade 1 strain near the knee may take 7 to 10 days to recover, while a mild strain near the ischial tuberosity may require at least 3 weeks to recover. Of course, optimizing speedy recovery requires good behavior on the part of the patient. The posterior compartment blends with the area of the posterior knee called the popliteal fossa. This is a fat-filled, diamond-shaped area posterior to the knee. It is bound superiorly by these diverging muscles of the hamstrings and inferiorly by the converging heads of the gastrocnemius and this muscle called the plantaris muscle. The roof is skin and popliteal fascia, while the floor is the joint capsule of the knee as well as the surface of the femur. The contents of the popliteal fossa include structures within the crural fascia and deep to the crural fascia. Here we can see those contents within the crural fascia, including the sural nerve, a cutaneous nerve that comes off the tibial nerve, but also gets contributions from the common fibular nerve. Here we can see that the sural nerve is essentially this structure here with contributions from the lateral portion. Structures in the popliteal fossa that are deep to the crural fascia include the popliteal vessels, the popliteal artery and vein. Remember, the popliteal artery was a continuation of the femoral artery after it came out through the adductor canal and then hiatus. The popliteal vein continues up and turns into the femoral vein after it goes through that hiatus. The sciatic nerve divides into two branches. Here we can see it dividing into the tibial nerve and the common fibular nerve, and these two nerves are found within the popliteal fossa as well. Note, sometimes the sciatic nerve may actually divide within the popliteal fossa. We've seen this slide before. We're going to take a look at it again so we can look at the dermatomal distribution seen on the left and the peripheral nerve distribution seen on the right of the posterior thigh. So in the dermatomal region, you'll notice this heavy strip of the S2 nerve root serving the posterior thigh. So for the guts of the posterior thigh, especially from this lateral side, we're looking at S2. Medially, we can see that there is this L3 distribution and laterally an L2 distribution. If we can see where that L2 distribution came from, as the L2 nerve root comes down and innervates much of the upper anterior thigh, there is this wraparound on the lateral side of L2. The cutaneous nerve distribution is similar in some fashion, where you have the central strip served by the posterior cutaneous nerve of the thigh. This is a new nerve, but we saw it as we looked in the gluteal region. Here we have the sciatic nerve coming out, and we saw that there is a posterior femoral cutaneous nerve that comes out underneath piriformis, along with that inferior gluteal nerve. Posterior femoral cutaneous nerve comes out, descends down along the posterior thigh to innervate this lower gluteal region, as well as the posterior thigh and the popliteal fossa. Medially, if you recall from the anterior medial thigh, there is a skin patch served by the obturator nerve. So we see that on the inner upper to middle thigh here. And laterally, we have the lateral femoral cutaneous nerve of the thigh that we saw both in the pelvis and then also in the anterior thigh, coming out and wrapping around to serve some of the posterior region as well. This area is served by the femoral nerve proper, and we can see that wrapping around medially and continuing on posteriorly a little bit. And that concludes our discussion of the posterior thigh as well as the gluteal region. Notice here we have an individual with hypertrophied muscles. We can actually see this semitendinosus muscle overlying, presumably this is the semimembranosus muscle medially. And here's the biceps femoris, long head with an underlying short head somewhere in here. Thank you for your attention, and if you have any questions or comments, please shoot me an email.